Hello, I'm Lester Rosen. I'm going to be interviewing Dr. Stephen Wexner, who was a past president of our society, and his presidency was 2011 to 12. Steve,
Lester.
when you did your initial general surgical training and thereafter through your colon rectal fellowship, who were your mentors? Got you interested?
I was very lucky. I was a general surgery resident at Roosevelt Hospital, and at that time, Tom Daly was the senior of the group. Rick Brabe was with Tom. There were a variety of other people who came and went during that period, but Tom was certainly the stalwart. A lot of people trained at Roosevelt in general surgery who then went into colorectal surgery because of Tom and Rick as mentors. Part of that mentorship included taking me and other people like Elliot Prager, who came there before me, to the New York Society of Colorectal Surgeons. And I got to start presenting at that society and meeting other surgeons at the society, even as a PGY 1, 2, 3. People like Sam Labow, who was president of the society, and Bart Hexter, who really revolutionized the way we did our audiovisuals in the society. Ken Ford from Columbia, who was one of the masters of surgical endoscopy and a past founder and president of SAGES. So I had indirect mentors because I used to see these people at the New York Society and was very stimulated by their careers. And I found as a group they were very embracing. I had gone to med school elsewhere in Manhattan and worked with people who were in other branches of surgery like cardiac and trauma and did not find them nearly as welcoming to a junior person and as nurturing to a junior person as I did these people from the New York Society, most of whom were not even in my hospital. And I had no clinical contact with them, but I had academic contact. Then at home I had Tom Daly encouraging me. Rick Brabe had me help him with his talks for Stan Goldberg's courses. Rick was one of not only a Roosevelt alumnus, but was also a University of Minnesota alumnus. And I went to the University of Minnesota, helped Rick with his course, with his lectures at Stan's course. And in the course of being there, got to meet a variety of people, one of whom on one occasion was Bill Heald. And I was early in my surgical career, and Bill Heald invited me to come visit him in Basingstoke, England. I think I was probably at most a PGY 3, and went to Basingstoke and met Bill and had a wonderful time, went to the operating room with him, spent time with him, and forged what's become at least 3-decade-long, very close friendship with Bill. So certainly Tom Daly, and Bill Heald as very direct mentors, a variety of indirect mentors. And then I got to go on to do my colorectal training with Stan Goldberg and David Rothenberger and the rest of the group at the University of Minnesota, who were also absolutely fabulous mentors, encouraging me in colorectal surgery throughout my fellowship. And just as Rick and Tom had gotten me to a place where I met Bill Heald and became a friend, Stan introduced me to David Jagelman, and David Jagelman hired me to go start Cleveland Clinic, Florida with him. And in October 1987, I signed up to be David's junior person at Cleveland Clinic, Florida. And that was very unique because for the first 2 years, I suppose, we had no residents or fellows, and Dave and I scrubbed together in all the cases. So I essentially did a super fellowship at the hands of a real master. That was an incredible 365 days a year working with somebody clinically, academically, research projects. So David was the next mentor in my line.
So with that big well of attendings, how did you get involved within the society in terms of committees? Like, what was your entryway into this long relationship with the society?
Well, ironically enough, if my memory serves correct, my first committee may well have been one that you were chairing, which was the Standards of Practice, sometime in the late 1980s, perhaps early 1990s at most, which was a real working committee, and the Self-Assessment Committee, which I think Paul Kowalczyk used to chair back then. Those two committees were assigned because of being real working committees, as well as with the journal that I was doing some of the, in those days we used to review, the editor-in-chief was before Bob Beert, before Vic Fazio and before Bob Beert were the editors-in-chief. We used to review articles on colorectal themes in other surgical journals and do little snippets, and I think Stan undoubtedly got me involved in that. So I was a little bit known, and then ultimately got into more of the reviewer business after I finished. So those are working committees, and the DCR was real work too. These were not committees that just met once a year to sit and have a lunch. These were real working committees, and the trick was to do the work.
And uniquely, you were involved in both the board and the Research Foundation, of which you were president of the board and now soon to be president of the Research Foundation. How did you get involved in those committees, and how did you grow in those committees?
Well, I think the idea is that if you have an interest, you pursue it. I had an interest, and I have several interests. I'm interested in research, I'm interested in education, I'm interested in clinical practice. So I became involved with each one. And for the board, it was a matter of always being available to write questions when asked and trying to write very good, thoughtful questions, well-referenced. When invited to be an associate examiner, to go and do the best job I possibly could as an examiner. For the Research Foundation, it was reviewing grants as requested. It was trying to submit grants so I had an interest. It's the same theme everywhere, to express an interest, and my advice to any person who wants to get involved in the society or the board or the foundation is let people know you're interested. Once you're given the opportunity, do the absolute best job you can and do it in a timely manner. And that's the way to get asked to do more things. The worst thing to do is say I'm interested and then don't follow through. Either don't perform at an optimal level, don't perform in a timely fashion, because that's the surest way that you're just going to be sort of an evanescent participatory or non-participatory member.
As one of the pioneers in laparoscopic surgery, there was certainly a transition from open to closed, and I think many future surgeons would want to know how you handle that, on many levels, both on a technical, on an ethical, on a teaching level, because you run a residency program, so I'm sure you're one of the people that they would look to for advice on just that one major transition.
It's interesting. Just today I happened to notice in the issue of General Surgery News that was distributed to us on registering at the meeting today, Rick Green's publication includes a large piece on the history of laparoscopic colorectal surgery, addressing exactly what you said. And I remember a little bit of history. I can tell you, to digress for a moment before I answer the question, but David Jagelman and I were invited to go with a group of people, including Ian Lavery and Harry Abkarian and Randy Bailey and others, to learn the techniques of laparoscopy, not even lap colon, because it wasn't being done, but to learn laparoscopy. And this was late 1990. And we were invited by one of the companies at that time to go to Palm Springs, California in December 1990. And then we were told that fell through, the Annenberg facility wasn't available, and we were going to go somewhere else. And with all due respect to my good friend and past President Al Thorson, we ended up in Omaha, Nebraska on February 3rd weekend, which was not exactly what we had been promised. But nonetheless, we learned from Bob Fitzgibbons, who was out in Omaha at the time, how to do lap cholecystectomies in pigs, and then said, okay, now you guys figure out what you're going to do with colons. And that was sort of our instant immersion, and we all started thinking, well, how can we do this and what can we do? And there was a huge flurry of activity from industry trying to come up with the tools we need to do those procedures. But we handled it in a measured, stepwise fashion to be ethical about it. And we would explain to our patients, we're doing something in a more minimally invasive fashion. We're going to have somebody here who does laparoscopy, like a gynecologist, with us in the OR, because they were doing a lot of diagnostic work. But a lot of what we did in the early days was mobilization of things, maybe a little bit of vascular control. It wasn't what we do now, where we can do a laparoscopic TME and a transanal specimen removal or transvaginal removal and intracorporeal reconstruction. So it was a different type of laparoscopy than we do. We approached it with caution. There were a lot of anecdotal published reports about port site recurrences, for example, and that led Heidi Nelson, Bob Beard, Jim Fleshman, me, others to get together and do a few things. Firstly, a registry that the Society published. Alan Thorson, I think, may have been the first author on that one. And then doing the cost trial, which ultimately Heidi presented at this society and published as the landmark study giving the green light to proceed with lap colectomy for cancer. But it was those questions in the early days that led us to put on not a red light but a yellow light, proceed with caution, do benign disease. The ASCRS under Bob Beard's presidency published statements saying that it's okay to do this in benign disease, but for malignancy, anything you do has to be captured in a meaningful registry that is internally captured and externally audited. And I think the society had a really fantastic leadership role in ensuring the safety of patients as laparoscopy proceeded.
Certainly the society would be interested in your role in international surgery. As I look at the history in my world, it was Harry Bacon was a big internationalist, and then Stan Goldberg was one of your mentors we knew that traveled. But how do you perceive colon rectal surgery outside the U.S. and equally important, how do people outside the U.S. perceive United States surgery?
Well, I think that people look to the U.S. for leadership in having education in colorectal surgery, because our model, the American Board of Colorectal Surgery, is, to my knowledge, the oldest such body for formalized skills assessment in colorectal surgery, skills verification, if you will, in an educational model. There are societies that are larger than ours. I would hazard a guess, without knowing exact numbers, that Japan and Brazil easily could have societies on par, if not larger, given the size of the population, perhaps China as well. But the definition of a colorectal surgeon may vary. So they look to us as to how to implement education, but it's grown tremendously and rapidly. In my career, in the last 30 years, I've seen the explosion of training programs, of recognition of colorectal surgery as a specialty, and even of societies. When I started training, there was no society in the UK. There was the section of coloproctology of the Royal Society of Medicine, but that's a very different body being part of the RSM, which is kind of like the AMA in a way. Very different than the Association of Coloproctology of Great Britain and Ireland, which was formed at a meeting in Harrogate in the UK in around 1990, give or take. There was no European Society of Coloproctology. I mean, these are new bodies that have come into being. The Australians, others have formed associations that didn't used to exist. So it's really exploded throughout the world. It's become a very sought after specialty. A lot of the other countries, as I say, have adopted our model. There's fantastic surgery going on all over the world. One thing I've always tried to do at the ASCRS is include international speakers because of the amount of incredibly interesting things that are done elsewhere, volumes of things, types of procedures, a lot of international developments. TME is out of the UK. The cylindrical abdominoperineal resection is being purported largely out of Sweden, Thorborn Holm. Werner Hohenberger with complete mesocolic excision, Germany. Phil Quirk with all he's done, again, in the UK. Like it or don't like it, PPH Longo coming out of Italy, sacral nerve stimulation, Klaus Matzel out of Germany, wait and watch approach, Angelita Habragama out of Brazil, the lift procedure, Aaron Rojanaskal out of Thailand. I mean, all of these are outside of U.S. development. STAR procedure, again, Italy, and I could go on and on. So although we're at the forefront of education and we do a lot of research and innovation, there's a lot going on throughout the world, and it's our job as leaders to find and work with those people and not work in isolation.
You know, as an educator in charge of a residency program, we all know that our residents are the future of the society. Looking forward, as far as you want to, how do you see the society changing or evolving?
I think it's going to become more of a, how would I say, but a social media savvy type of society where a lot of things will happen outside of the annual meeting. A lot of things will happen, perhaps committees meeting by GoToMeeting or other similar web platforms, people getting information through Twitter feeds and the like. The journal being more multimedia and including more video clips and things that can be downloaded, more webinars. Again, as meetings are having, all meetings are having harder and harder times being financed, and practices are having to work harder to make the same money, perhaps even work harder to make less money. People are tending to travel less. So I think the society is going to rise to that task, but we have a lot of very intelligent, multimedia savvy people and social media savvy people who are going to help drive that forward. If we do it, we'll certainly be amongst the global leaders in colorectal surgery in years to come, and I'm sure that will happen. We certainly have a head start, if nothing else, since 1899.